1, 2,
And review, somebody female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision.
Right. Yeah, like it's binary.
Exactly. It's almost like engineering. If a patient comes in with a broken arm, the X-ray shows that jagged white line. The doctor points to it and says, you know, there it is.
Yeah, and it's comforting because we like things to be visible. We like our pathology to be neatly categorized in a little box.
But then you step into the world of postpartum nursing care, and suddenly that X-ray machine is, well, it's entirely useless.
No, completely.
We are looking at a physiological landscape that is, honestly, it's a massive, rapid biological earthquake. So welcome to a very special clinical coaching session.
I am so excited for this one.
If you are stepping into the shoes of a nursing student, prepping for the NCLEX, or getting ready to be a future OB nurse, you are in the exact right place. Our mission today is clear. We're doing a deep dive into the most critical, highly tested, and clinically vital aspects of postpartum maternal physiological adaptations and nursing care.
That is a mouthful, but yeah, it's vital.
It is. I'm your resident study buddy. I've been poring over the source material, trying to synthesize all the madness, and joining us is our elite OB clinical mentor and exam coach.
I am absolutely thrilled to be here with you. And my goal today is to apply the Pareto principle aggressively to your studying and your clinical practice.
So the 20/80 rule.
Exactly. We're going to sift through all of these sources and identify the 20% of concepts, physiological patterns, and, high-yield facts that will give you 80% of your exam and clinical success.
Which is a relief because there is so much material.
Right. We are not going to waste your time trying to teach every single detail equally. We are pulling forward the most testable, most repeated, and most safety-critical content first.
And what's fascinating is that postpartum care isn't just about handing the parents a beautifully swaddled baby, snapping a quick photo, and waving goodbye as they leave the hospital.
Not even close. I mean, it is a massive, rapid biological shift that involves genuine, sudden, life-threatening risks. Yeah. We expect a patient's body to drop from this hypervascular, hormone-flooded state back to a non-pregnant baseline in just 6 to 12 weeks.
Which is wild when you think about it.
It really is. And the reality is the risks for hemorrhage, infection, and severe complications are lurking right beneath the surface of what looks like a happy, routine moment.
Exactly. So by the end of this deep dive, you will know exactly how to spot a hemorrhage before the blood pressure even drops.
Yep, highly testable.
You'll understand the exact mechanism of why a full bladder is literally a medical emergency in obstetrics. And you'll know how to dodge the absolute most common NCLEX-style traps that instructors just love to set up. We're going to help you think like a safe, sharp future nurse.
Absolutely. We're going to break this down physiologically. Yeah. We won't just tell you what to memorize. We're going to explain the why and the how behind the physical changes.
Because when you understand the mechanism, you don't have to rely on rote memorization.
Right. The answers on your exams and in your patient's room will just make sense.
So let's start where the immediate danger is. The bleeding and the cramping. Uterine involution and lochia.
The high-yield core.
Yeah. When I was reading the sources, I kept thinking of the pregnant uterus like a giant overinflated balloon. During pregnancy, this balloon stretches to hold a baby, amniotic fluid, and a placenta, going from weighing about 50 grams to roughly 1,000 grams.
That's a massive increase.
Right. But after birth, that balloon needs to deflate rapidly down to about 100 grams. And if that balloon stays floppy, we have a major problem. But I want to move past the balloon metaphor because it doesn't quite explain the bleeding. What is actually happening inside that organ?
Well, the balloon is a good start for size, but to understand the bleeding, you need to picture the uterine lining. When the placenta peels away from the uterine wall, it doesn't just detach cleanly like a sticker. It tears away, leaving behind a massive open wound with exposed raw blood vessels. We are talking about a wound the size of a dinner plate inside the uterus.
Oh, wow. That is a terrifying visual. A dinner plate-sized open wound.
It is. And in any other part of the body, if you had a wound that size with severed blood vessels, a surgeon would have to go in and cauterize or stitch every single bleeder.
Right, you'd be in the OR immediately.
Exactly. But the body has this brilliant evolutionary mechanism to handle this. The myometrium, which is the uterine muscle, is structured like a complex basket weave.
Okay.
When the baby and placenta are delivered, those muscle fibers must clamp down incredibly hard. As they contract, they physically crimp and crush those bleeding vessels, acting like a biological tourniquet.
Wow.
And this process of shrinking and clamping is called uterine involution.
Okay, so the cramping the patient feels postpartum, which we call after pains, is literally the body applying an internal tourniquet to save her life.
Precisely. If the uterus does not contract, a condition we call uterine atony, meaning without tone, or a boggy fundus, those massive blood vessels remain wide open.
And then what happens?
The patient will bleed out incredibly fast. This leads directly to postpartum hemorrhage, which can become fatal in a matter of minutes.
So, as a nurse walking into the room for an assessment, I need to know if that tourniquet is working. How do I physically measure that?
Your priority assessment immediately postpartum is palpating the fundus, which is the top rounded portion of the uterus.
The top part. Got it.
Right. When you push down on the abdomen, the fundus should feel firm, like a tightly flexed muscle or a hard grapefruit. It should be located midline, exactly in the center of the abdomen, and usually right after birth, you'll feel it somewhere between the symphysis pubis and the umbilicus.
But it moves. Right. The sources highlighted the timeline of where that fundus should be at different hours and days.
Yes, and this is extremely high yield for exams. By about 12 hours postpartum, the fundus actually rises up to the level of the umbilicus.
Wait, it goes up first?
Yeah, it temporarily rises, but from there, the rate of descent is very predictable, which is why we tracked it so closely. It should decrease by 1 centimeter, which is roughly 1 finger breadth per day. So on day 1, it's 1 centimeter below the umbilicus. Day 2, 2 centimeters below. By week 2, it should have descended entirely back into the true pelvis, meaning you shouldn't even be able to palpate it abdominally anymore.
Okay, so if I palpate the abdomen and I don't feel a firm grapefruit, if I feel something soft, mushy, or boggy, my alarms are going off. What is the immediate physiological nursing action?
If the fundus is boggy, your immediate, absolute first action is to perform fundal massage. You do not leave the room. You do not call the provider first. You do not chart it first.
You just go right for it.
Exactly. You place one hand right above the symphysis pubis to support the lower uterine segment. This prevents you from literally inverting the uterus out of the body, which is a rare but catastrophic complication.
Yeah.
And you use your other hand to firmly massage the fundus.
You're agitating it.
Right. You are physically agitating that muscle to force it to contract and apply that biological tourniquet.
That sounds incredibly painful for the patient.
It is very uncomfortable, and you must communicate what you're doing and why. Like, I need to press firmly on your stomach to help your uterus shrink and stop the bleeding, but it is a life-saving intervention.
While we're talking about bleeding, we have to discuss Lochia, the vaginal discharge after birth. I think a lot of people just assume it's like a really heavy period, but the physiological makeup of Lochia is different, isn't it?
It's very different. Lochia isn't just blood. It's an exudate consisting of red blood cells, shed decidual tissue from the uterine lining, amniotic fluid remnants, cervical mucus, and even bacteria.
A whole mix of things.
Yep. The progression of Lochia is highly testable because it tells us exactly how that dinner plate wound is healing.
Walk me through the stages.
Sure. Days 1 through 4, we expect Lochia rubra. Rubra means red. It's dark red because it is primarily composed of blood and decidual and trophoblastic debris.
Okay, so rubra first.
Right. From days 4 through 10, it transitions to Lochia serosa. Serosa is pink or brownish. It's pink or brown because the active bleeding has stopped, and it's now mostly old blood, serum, leukocytes, and tissue debris.
Got it.
Finally, from days 10 to 14, and sometimes lingering up to 6 weeks, it becomes Lochia alba. Alba means white or yellowish. This is mostly leukocytes, decidua, epithelial cells, fat, and cervical mucus.
Let me lock in a memory anchor for that. Rubra, serosa, alba. Rubra is red in first. Serosa is sunrise, kind of pinkish brown in the middle. Alba is alabaster, white in last.
That is a perfect memory hook. Rubra, serosa, alba. Red, sunrise, alabaster.
So how do test writers trap students with Lochia? Because it seems pretty straightforward.
The biggest trap is confusing the timeline. Test questions love to give you a scenario like, a patient is day 5 postpartum and reports bright red vaginal bleeding. What is the nurse's priority?
Let me guess, they offer options like document as a normal finding.
Yes. And students think, well, she just had a baby, of course she's bleeding. But you must recognize that at day 5, the lochia should be serosa pink or brown.
Right.
Bright red bleeding at day 5 is highly abnormal and indicates a problem. Most commonly retain placental fragments that are preventing the uterus from fully clamping down.
Oh, because if even a tiny piece of the placenta is left behind, the muscle fibers can't cinch down tightly around it.
Exactly. It basically props the wound open. Another common trap is assuming a cesarean birth has more lochia because it's a major surgery.
That makes intuitive sense, though.
It does, but in reality, they generally have less lochia. During a C-section, the surgeon physically swabs and cleans out the uterine cavity with surgical sponges before suturing it closed.
Oh.
They manually remove a lot of the debris that a vaginal birth patient has to expel naturally.
That makes total sense. The surgeon literally does the cleanup. What about the volume of bleeding? How do we objectively measure what is too much?
We measure it by the saturation of perineal pads over time. Expected findings include scant to moderate lochia. You might also see some small clots, maybe the size of a grape or small plum.
Okay. Grapes are fine.
Right. And this is especially common when the patient first stands up after resting in bed for a few hours because the lochia has been pooling in the vagina. When they stand, gravity does its job and there's a gush. That's normal.
But what is the threshold for panic?
The threshold for immediate intervention is saturating a perineal pad in less than 1 hour. If you put a clean pad on a patient and 45 minutes later it is completely soaked through from front to back, that is a hemorrhage until proven otherwise.
That's a lot of blood.
It is. Also, any clots larger than a chicken egg are a massive red flag. If you see an egg-sized clot, you need to examine it. We literally break it apart to see if there's placental tissue inside it.
Okay, if we distill this entire discussion on uterine involution and lochia down to the most critical, high-yield points, what are the top 5 takeaways a student or nurse must remember?
Okay, number 1. The fundus descends 1 centimeter per day after hitting the umbilicus at the 12-hour mark. Number 2. If the fundus is boggy, your immediate first action is to massage it.
Right, massage first.
Number 3. Saturating a pad in less than 1 hour is a hemorrhage priority. Number 4. Clots larger than a chicken egg require immediate investigation. And number 5. Lochia rubra lasting past 4 days or returning to bright red after transitioning to serosa is a severe red flag for retained placental fragments.
Fantastic. So if the uterus is doing its job, it is clamping down and squeezing all that blood that was flowing to the placenta back into the mother's systemic circulation. Her blood volume just surged. How does the heart handle that?
It's a huge cardiovascular shift.
Because that brings us to the cardiovascular, vital sign, and hematological shifts. The great fluid dump. And I really want to challenge you here because my med-surg instincts were screaming when I read the source material.
I love when med-surg instincts clash with obstetrics because that is exactly where students fail the NCLEX. What stood out to you?
If I am on a standard adult medical floor and I look at a patient's chart and their white blood cell count is 25,000 and their heart rate is 55 beats per minute, I am reaching for the crash cart.
Oh, for sure.
I'm thinking they have a massive, overwhelming sepsis infection, their body is decompensating, and they are sliding into shock. But in OB, the reading says this is normal.
It is completely normal in the immediate postpartum period, and this requires a massive paradigm shift. Let's look at the physiological mechanism, starting with the heart rate. During pregnancy, maternal blood volume increases by almost 50%.
That's so much extra fluid.
It is. When the placenta is delivered, all the blood that was previously shunted to the uteroplacental circuit, roughly 500 to 750 milliliters per minute, is suddenly dumped back into the maternal systemic circulation. This is basically an auto transfusion.
So her cardiac output just skyrockets.
It spikes by 60 to 80% immediately postpartum. Because there is suddenly so much more fluid in her vessels, her stroke volume, which is the amount of blood pumped out with each heartbeat, increases significantly.
Oh, so the heart doesn't have to work as hard.
Exactly. Because each beat is pushing so much more blood, the heart doesn't have to beat as fast to maintain adequate circulation. So a heart rate of 50 to 90 beats per minute postpartum bradycardia is an expected, healthy physiological adaptation.
Wow. Okay, so bradycardia is normal. What about the white blood cells? Because 25,000 is astronomically high. How is that not an infection?
The mechanism here is absolutely fascinating. It's a phenomenon called demargination. To understand this, picture the inside of a blood vessel. Normally, a large percentage of white blood cells aren't actively circulating. They are marginated, meaning they are clinging to the walls of the blood vessels.
Like they're just hanging out.
Yeah, hanging out like bats on the ceiling of a cave.
Just waiting to be needed.
Exactly.
Yeah.
But labor and birth are intensely physically and emotionally stressful. The body is flooded with adrenaline, cortisol, and massive tissue trauma. This stress response causes the blood vessels to constrict and the blood flow to become turbulent.
And the bats fall off.
Yep, all of those bats clinging to the walls get shaken loose into the active bloodstream. So when we draw blood, the total circulating count spikes up to 25,000 or even 30,000 per cubic millimeter. But it's not because there is an invading pathogen, it's simply a mechanical and chemical stress response.
That is such a clear visualization. Demargination. The bats getting shaken loose. So how does an instructor test this and try to trap a student?
They will present a scenario. A patient is 24 hours postpartum, her temperature is 100.2 degrees Fahrenheit, and her white blood cell count is 22,000. What is the priority nursing action?
Let me guess. Option A is notify the provider and prepare to administer broad-spectrum antibiotics.
Exactly. And students jump on option A because they see a slight fever and high WBCs, but the temperature of 100.2 is normal in the first 24 hours due to the sheer physical exertion and dehydration of labor.
Makes sense.
And the WBCs are normal due to demargination. The correct answer is document the findings as expected and encourage oral fluids. If you act on med-surg parameters, you will call the provider in a panic over a perfectly healthy patient.
Let's talk about the fluid volume again. We've got this massive autotransfusion. The body has to get rid of that extra 50% blood volume eventually, right?
It does, and it does so aggressively. To dump the excess extracellular fluid of pregnancy, the body initiates profound diuresis and diaphoresis.
So peeing and sweating.
Yep. A postpartum patient might urinate up to 3,000 milliliters, 3 liters of urine a day for the first few days, and they will experience severe diaphoresis. They will wake up in the middle of the night completely drenched in sweat, completely soaking their hospital gown and sheets.
And again, if I'm not thinking OB, night sweats make me think of like tuberculosis or lymphoma, but here she's just dumping pregnancy fluid.
Precisely. It is the body's natural diuretic system at work.
We talked about expected vital signs. Let's talk about the red flags. If bradycardia is normal, what is the canary in the coal mine for something going wrong?
Tachycardia. In a standard med-surg environment, if a patient is bleeding internally, we often wait to see the blood pressure drop. In obstetrics, relying on blood pressure is a fatal mistake.
Really? Why?
Because pregnant and immediately postpartum individuals are young, healthy, and have expanded blood volumes. Their bodies are incredibly adept at compensating for blood loss. They will clamp down their peripheral vessels to maintain blood pressure even as they bleed out.
Oh, wow.
Yeah. By the time their blood pressure actually drops, they have lost 25 to 30% of their total blood volume, and they are in the late stages of hypovolemic shock.
That is terrifying.
It is. The very first measurable vital sign change in a postpartum hemorrhage is tachycardia. If you have a patient whose heart rate was 65, and an hour later it is 105, and an hour after that it is 120.
You don't wait.
You do not wait for the blood pressure to change. You need to be aggressively hunting for blood. You massage the fundus, you check the perineal pad, you look under the patient's buttocks because blood can pool there unnoticed. Tachycardia is your early warning siren.
What about labs? Can we just check a hemoglobin and hematocrit to see if they're bleeding?
No, and that is another massive trap. Hemoglobin and hematocrit, the H&H, are wildly unreliable indicators of blood loss in the first 24 hours.
Is that because of the fluid shifts?
Exactly. Because of hemodilution, the extravascular fluid is being pulled back into the vascular system to be peed out. This dilutes the blood. You might draw an H&H and it looks artificially low just because there's so much plasma volume.
Or it could look high if they're dry.
Exactly. If the patient is dehydrated, it might look artificially high. You cannot rely on lab values on day one. You must rely on your physical assessment, the firmness of the fundus, the visible lochia, and the heart rate.
There's one more hematological shift we have to touch on, and it's the clotting factors.
Yes. During pregnancy, clotting factors and fibrinogen levels increase dramatically. Evolutionarily, this is a protective mechanism to ensure the mother doesn't bleed to death when the placenta detaches. The blood becomes hypercoagulable.
But there's a downside to that.
There is. The problem is, these clotting factors remain highly elevated for several weeks postpartum.
Which means they are at a massive risk for blood clots.
A profound risk for deep vein thrombosis, or DVT, and subsequently pulmonary embolism. So your priority nursing action is assessing the lower extremities. You are looking for unilateral calf pain, swelling, erythema, and warmth.
And we measure the calves, right?
Yes, if you measure the calves, a circumference difference of more than 2 centimeters between the right and left leg is highly concerning. You must encourage early and frequent ambulation to keep that thick, hypercoagulable blood moving.
The memory anchor from the notes is perfect here. Postpartum blood is thick and fast. Thick because of the high clotting factors, which means high DVT risk. Fast because of the autotransfusion and the resulting tachycardia if they start hemorrhaging. Thick and fast.
That's it. Keep that front of mind.
Okay, what are the 5 absolute must-know takeaways for the great fluid dump?
Number 1. White blood cells naturally spike up to 25,000 due to the stress of labor, which is not an automatic infection alert. Number 2. Tachycardia is your primary early red flag for hemorrhage. Do not wait for hypotension.
All right, don't wait for BP to drop.
Number 3. Elevated clotting factors mean a high DVT risk, so always assess the legs and get the patient walking. Number 4. Hemoglobin and hematocrit are unreliable indicators of actual blood loss in the first 24 hours due to massive fluid shifts. And number 5. Profuse sweating and urinating up to 3 liters a day is the body's expected, healthy mechanism for dumping excess pregnancy fluid.
Let's keep moving through the body, following the logic of what we just discussed. We just established that the patient's kidneys are working overtime to process and pee out 3 liters of fluid. But what happens if that fluid can't get out?
Oh, plumbing problems.
Yes, because the bladder just went through a literal war zone.
Yeah.
We're moving to the plumbing problems, renal and gastrointestinal systems.
This is where anatomical geography becomes incredibly important.
When I visualized this, I thought of an 18-wheeler parked on a 1-lane road. If the bladder is completely full of all that diuretic fluid, it physically sits right in the way of the uterus.
It's an excellent visual. Let's map the anatomy. The bladder sits anteriorly, directly beneath and slightly in front of the lower uterine segment. Normally, when the bladder fills, it expands upward, but postpartum, the uterus is sitting right there.
Right in the way.
Exactly. If the bladder fills with hundreds of milliliters of urine, it acts like a water balloon inflating underneath the uterus. It physically pushes the uterus upward and, most commonly, deviates it to the right side of the abdomen.
Why the right side? Is there a reason?
Mostly because the sigmoid colon occupies space on the left side of the pelvis, so the path of least resistance for a displaced uterus is upward and to the right. But the danger isn't just that it moved. The danger is what happens to the muscle fibers.
Oh, the basket weave.
Yes. When the bladder pushes the uterus out of place, it severely stretches the uterine ligaments. Because those ligaments are stretched tight, the basket weave muscle fibers of the myometrium cannot cinch down properly.
So a full bladder physically prevents uterine involution. The biological tourniquet gets jammed.
Precisely. Urinary retention is a direct primary cause of postpartum hemorrhage. And the terrifying part is that postpartum patients often have no idea their bladder is full to the point of bursting.
How is that possible? I mean, I know when I have to pee.
Several reasons. First, if they had an epidural, the neurological signals from the bladder to the brain are blunted or still entirely numb. Second, the sheer physical trauma of a baby's head grinding against the urethra during birth causes massive tissue edema. The urethra can be so swollen that urine can't pass.
Ouch.
Third, they might have received oxytocin during labor, which has a mild antidiuretic effect, and when it shut off, the kidneys fled the bladder rapidly. Finally, psychological fear. They know it's going to burn to pee because of microscopic or macroscopic tearing, so they subconsciously hold it.
So as the nurse, what is the protocol? How long do we let them wait before we intervene?
The standard of care is that the first void must happen within 6 hours of birth, or within 6 hours of a Foley catheter being removed. And it's not just about them peeing once, it's about making sure they actually empty the bladder.
Because they could be retaining fluid.
Right. A patient might void 100 milliliters, but because of the swelling, they are retaining 600 milliliters. We often use a bladder scanner, which is an ultrasound device, to measure the post-void residual. It must be less than 150 milliliters to ensure we aren't setting them up for a hemorrhage or a urinary tract infection from stagnant urine.
Let's talk about the NCLEX trap here because it's legendary.
It is the ultimate prioritization question. The scenario will read: the nurse assesses a postpartum client and notes a boggy fundus displaced 2 centimeters above the umbilicus and deviated to the right, What is the priority nursing action?
And because instructors have beaten massage the boggy fundus into every nursing student's head, everyone immediately clicks massage the fundus.
Yes, they do. And they get it wrong, because if the fundus is deviated up and to the right, the bladder is full. Massaging the fundus when it's stretched over a distended bladder is intensely painful, and it won't fix the underlying problem.
You'll just go boggy again.
As soon as you start massaging, it will become boggy again. You have to remove the roadblock first. The priority action is to assist the client to the bathroom to empty their bladder. If they cannot void, or if they have an epidural and cannot walk, you must straight catheterize them to drain the urine. Only after the bladder is empty do you massage the fundus.
The memory anchor is crucial here. A full bladder is a roadblock to a firm fundus. You cannot fix the road until you move the 18-wheeler.
Exactly. Assess position first. If it's deviated, empty the bladder.
What about the GI tract? Because pushing out a baby takes a toll on the other plumbing, too.
The gastrointestinal tract is incredibly sluggish postpartum. Part of this is chemical. Progesterone levels were sky high during pregnancy to relax the smooth muscle of the uterus so it wouldn't contract early. But progesterone isn't localized. It relaxes all smooth muscle, including the intestines.
So digestion just slows way down.
So peristalsis is very slow.
Right.
Add to that the administration of opioid pain medications, which cause severe constipation, and the dehydration from labor.
I would imagine there's a massive psychological component here, too.
A profound one. About 11% of vaginal births involve an obstetric anal sphincter injury, or OASI. This means they tore through the perineum and into the muscle of the anal sphincter, or even entirely through it into the rectal mucosa.
That sounds horrific.
Even if they didn't tear, they likely have severe engorged hemorrhoids from the pushing phase. The psychological terror of having a bowel movement with those injuries is immense. Patients will subconsciously clench and hold their stool, leading to severe fecal impaction, which stretches the healing tissues and causes agonizing pain.
That sounds like an absolute nightmare. How do we proactively manage that?
Priority nursing actions revolve around staying ahead of the constipation. We aggressively administer docusate sodium. This is not a stimulant laxative, it's a surfactant.
The surfactant, what does that do?
It lowers the surface tension of the stool, allowing water and fats to penetrate it, making it soft and easy to pass without straining. We also emphasize hydration and early ambulation, which physically stimulates peristalsis.
Okay, before we leave the physical plumbing and structure, the notes mentioned diastasis recti. I see a lot of fitness influencers talking about this.
Diastasis recti is the separation of the rectus abdominis muscles. As the uterus grows, the linea alba, the connective fascia running down the center of the abdomen, stretches and thins out. After birth, the muscles are physically separated. When the patient tries to sit up or lift their head, you will see a visible ridge or tenting protruding down the middle of their abdomen.
Is that an emergency? Does it require surgery right away?
No, and that's an exam trap. It is an expected normal finding, especially in subsequent pregnancies or with large babies. It requires time, core-specific physical therapy, and modifying exercises to allow the fascia to heal. It is not an acute medical issue.
All right, what are the 5 must-know takeaways for the plumbing problems?
Number 1, a deviated boggy uterus means the bladder is full. The priority is emptying the bladder either by voiding or catheterization before massaging. Number 2, the first void must occur within 6 hours of birth.
Or 6 hours after Foley removal.
Yes. Number 3, post-void residual must be kept under 150 milliliters to prevent hemorrhage and infection. Number 4, constipation is a massive threat due to progesterone, opioids, and psychological fear. Treat it proactively with docusate sodium and hydration. And number 5, diastasis recti is an expected finding of muscle separation that requires time and targeted therapy, not surgical intervention.
We have stabilized the uterus, we've managed the massive fluid shifts, and we've cleared the plumbing roadblocks. But all of this physical machinery is being driven by invisible chemical signals.
The hormones.
Let's move to the endocrine system and lactation. The hormone crash. The physical shifts are wild, but the chemical shifts seem even more volatile.
The endocrine shift after birth is one of the most drastic, precipitous hormonal crashes a human being can endure, and it all centers around the delivery of the placenta.
Because the placenta isn't just a filter for the baby, right? It's an active organ.
It is a massive temporary endocrine gland. It pumps out enormous quantities of estrogen, progesterone, human chorionics, gonadotropin, or HCG, and human placental lactogen, or HPL. The moment the placenta detaches and is delivered, the source of those hormones is completely removed.
So they just drop off a cliff.
Exactly.
Okay.
Estrogen and progesterone levels plummet immediately. HCG drops to 0 by the end of the first week.
How does that crash trigger milk production? Because during pregnancy, the breasts enlarge, but they aren't, leaking gallons of milk. What holds the milk back?
Estrogen and progesterone are the brakes. During pregnancy, the anterior pituitary gland is secreting prolactin, the hormone that produces milk. But the massive levels of placental estrogen and progesterone actively inhibit the prolactin from working on the breast tissue.
Oh, I see.
When the placenta is delivered, the brakes are suddenly removed. Estrogen and progesterone crash, and prolactin is allowed to surge, initiating lactogenesis or milk production.
I love knowing the exact mechanism. So prolactin produces the milk, but how does it get out?
That is the role of oxytocin, which is secreted by the posterior pituitary gland. When the baby suckles at the breast, it sends a neurological signal to the brain, releasing oxytocin. Oxytocin causes the myoepithelial cells around the milk ducts to contract, squeezing the milk out. This is called the letdown reflex.
Wait, oxytocin, isn't that the same hormone that causes the uterus to contract?
Yes, it has a dual role, and this is why when a mother puts the baby to the breast, she will often feel intense, painful uterine cramping. It's the oxytocin working on both the breast tissue and the uterine myometrium.
That's a brilliant biological design. Breastfeeding actively promotes uterine involution and prevents hemorrhage.
It really is.
Prolactin produces, oxytocin oozes. That's the memory hook. Prolactin makes it, oxytocin ejects it.
Perfectly stated.
Now, I want to ask about a massive myth I hear constantly. The idea that breastfeeding is a perfect form of birth control. The clinical term in the reading is lactational amenorrhea. Explain the actual mechanics of this, because I know people who have gotten pregnant 3 months postpartum while breastfeeding.
It is a huge myth if not understood with clinical precision, and exam writers love to test this. The theory is that high levels of prolactin suppress the release of gonadotropin-releasing hormone, or GnRH, which in turn suppresses ovulation. No ovulation means no period, which is amenorrhea, and no pregnancy.
But there's a catch.
A massive catch. Lactational amenorrhea is only effective for about 6 months, and only if the criteria are met flawlessly. The infant must be exclusively breastfed. Not mostly breastfed, exclusively. No formula supplementation, no pacifiers, and the baby must feed constantly around the clock, including multiple times at night.
Why does that matter?
Because the suckling stimulation is what keeps the prolactin high. If a baby starts sleeping through the night for 6 hours, the mother's prolactin levels dip. When prolactin dips, the suppression on GnRH lifts, and the ovaries prepare an egg. And here's the trap. Ovulation returns before menstruation.
Oh, so a patient could release an egg, have unprotected sex, and get pregnant before she ever sees her first postpartum period.
Exactly. She'll say, but I haven't had a period yet. It doesn't matter. The egg comes first. Therefore, patient education is critical. If they do not want to become pregnant, they must use a reliable alternative form of contraception, regardless of whether they are breastfeeding or bleeding.
What about patients who have diabetes? Does the hormone crash affect them?
Profoundly.
Yeah.
Let's go back to the placenta. One of the hormones it secretes is human placental lactogen, or HPL. HPL is diabetogenic. It actively creates insulin resistance in the mother's cells, ensuring that plenty of glucose remains in the bloodstream to cross the placenta to the baby.
So they need more insulin while pregnant.
Right. Because of this resistance, diabetic mothers require huge amounts of insulin during late pregnancy.
So when the placenta is delivered,
The HPL is gone instantly, the insulin resistance vanishes, her cells become highly sensitive to insulin again. If she takes her pregnancy dose of insulin on day 1 postpartum, she will crash into severe, potentially fatal hypoglycemia.
and a huge safety issue.
A massive one. A priority nursing action is knowing that a diabetic patient's insulin requirements will drop drastically, sometimes by half or more immediately after birth. You must monitor their blood glucose closely and anticipate a much lower insulin order.
Let's pivot to the physical act of lactation. What are we assessing and what is concerning?
For expected findings, you expect to see colostrum for the first 2 to 3 days. This is the thick, yellowish, incredibly nutrient and antibody-dense early milk. Around 72 to 96 hours postpartum, the mature milk comes in, causing primary engorgement. The breasts become full, heavy, and warm.
What is concerning?
Nipple trauma and lash pain. Breastfeeding might feel uncomfortable for the first few seconds as the tissue stretches, but it should not be painful. Severe pain, cracking, bleeding, or blistering means the baby is latching poorly and chewing on the nipple rather than drawing the areola into their mouth.
How do we fix a bad latch?
First, teach the mother what a good latch looks like. The baby needs a wide, gaping mouth, like a massive yawn. The baby's chin should be buried deeply into the lower breast, and the mother should be able to see more of the dark areola above the baby's top lip than below the bottom lip.
And if it still hurts?
If it hurts, the priority intervention is to stop the feed. But you never just pull the baby off the breast.
Why not?
Because their suction is incredibly strong, and you will literally tear the mother's nipple tissue. The nurse must instruct the mother to insert a clean pinky finger into the corner of the baby's mouth to physically break the suction seal before pulling the baby away. Then try again.
What about patients who are choosing formula feeding or who suffered a fetal loss and are not taking a baby home? The milk is still going to come in. How do we stop it?
This is a critical compassionate care and physiological intervention. For non-lactating clients, the priority is absolute suppression. We do not use medications to dry up milk anymore due to severe side effects. Instead, we use physical measures. The mother must wear a tight, supportive sports bra 24 hours a day. Apply ice packs or cold, crushed cabbage leaves to the breasts. The cold causes vasoconstriction, reducing blood flow and milk production. Most importantly, absolute zero stimulation.
No hot showers.
She should face away from the water in a warm shower because warm water running over the breasts will trigger a letdown. If she pumps just a little bit to relieve pressure, she signals the brain to make more. She must leave it entirely alone.
Okay, distill the hormone crash and lactation down to the top 5.
Number 1. The precipitous drop in placental estrogen and progesterone removes the brakes, allowing prolactin to surge and initiate milk production. Number 2. Never forcibly pull a baby off the breast. Always break the suction seal with a finger.
Use the pinky.
Number 3. A painful latch is a bad latch. Stop, break the seal, and reposition. Number 4. Diabetic patients will experience an immediate drop in insulin resistance postpartum and will require drastically lower doses of insulin to avoid hypoglycemia. And number 5. To suppress lactation, use continuous cold therapy, a tight bra, and avoid absolutely all breast stimulation.
That brings us nicely into section 5, comfort and chemistry. We are talking about perineal care, pain management, and the specific pharmacology of the postpartum period.
This is where we do a lot of teaching.
Yeah, because we've established that there is severe uterine cramping, breast pain, and potential trauma to the perineum. Navigating pain management here feels like walking a tightrope. You have a patient healing from significant physical trauma, but you also have to work about medications passing through breast milk and the ever-present crisis of opioid addiction.
It is a very delicate balance, and it requires a stepwise, highly systematic approach. We start with a meticulous assessment of the perineum to understand exactly what we are treating. We use the RITA scale.
Break down the RITA scale for me.
RITA is an acronym that reads the wound. R stands for redness, indicating inflammation. E is for edema, or swelling. E is for ecchymosis, which is... Wait, ecchymosis is just clinical bruising, right? Exactly, bruising. D is for discharge, looking for purulent or foul-smelling drainage. A is for approximation, which means looking at how tightly the sutured wound edges are pulling together. Each category is scored. A score of 0 means perfect healing. A high score means the wound is infected, separating, or developing a hematoma.
Why does this perineal assessment matter so much clinically?
Because up to 79% of vaginal births involve some degree of perineal trauma. We categorize tiers from 1st degree, which is just superficial skin, all the way to 4th degree.
And 4th degree is the worst one.
A 4th degree tear rips through the vaginal mucosa, the perineal body, completely severs the anal sphincter muscle, and breaches the rectal mucosa. How we manage this healing impacts a patient's lifelong pelvic floor function, their ability to control their bowels, and their sexual health.
That is immense. So how do we treat the pain and promote healing without just handing out heavy narcotics?
We use a stepwise approach, starting with non-pharmacological interventions. Timing is everything here. In the first 24 hours after birth, the priority is cold therapy. We apply ice packs to the perineum. The cold causes vasoconstriction, which reduces acute edema, stops capillary bleeding, and numbs the nerve endings.
Well, we don't use ice forever.
No. After 24 hours, the acute inflammatory phase has peaked, and we need to promote tissue repair. So we switch from cold to warm. We use warm sitz baths. The patient sits in a shallow basin of warm water.
Did you bring blood flow back?
Yes. The warmth causes vasodilation, bringing fresh oxygen-rich blood and white blood cells to the perineum to accelerate healing. But here is the safety priority. The water temperature must be strictly monitored between 34 to 37 degrees Celsius.
Why the strict temperature limit?
Because the perineum is highly sensitive and often numb from trauma or medication. If the water is too hot, they will sustain severe thermal burns without realizing it until the damage is done.
Let's move to the pharmacology, because I know this is where the NCLEX writers get vicious.
They absolutely do. You must maximize non-opioid scheduled medications before you reach for breakthrough narcotics. The key players are acetaminophen, ibuprofen, and a topical anesthetic spray called benzocaine, often known by the brand name Dermoplast.
Let's talk about the specific toxicities, because you can't just mix these up.
Exactly. Instructors will test if you understand the pathways. Acetaminophen is processed by the liver. Its major toxicity is hepatotoxicity. If a patient takes too much, a toxic metabolite called NAPQI builds up and destroys liver cells.
So if a patient has liver issues.
Right. If an exam question gives you a postpartum patient with a history of severe hepatitis or liver disease and asks which pain vet is contraindicated, the answer is acetaminophen.
Ibuprofen.
Ibuprofen is an NSAID. It works by inhibiting prostaglandins, which are the chemicals that cause inflammation and uterine cramping. But prostaglandins also protect the stomach lining and regulate blood flow to the kidneys. So, ibuprofen carries a high risk for gastrointestinal bleeding and nephrotoxicity kidney damage.
So no NSAIDs for ulcer patients.
Correct. If a patient has a history of peptic ulcers or chronic kidney disease, ibuprofen is contraindicated.
Wait, I have a physiological question. If ibuprofen inhibits prostaglandins and prostaglandins cause the uterus to cramp, doesn't giving ibuprofen stop uterine involution and cause a hemorrhage?
That is brilliant critical thinking and a very common question. The answer is no, because of the scale of the hormones involved. The massive surge of oxytocin driving uterine involution completely overpowers the mild prostaglandin inhibition of an oral NSAID dose.
Oh, the oxytocin just outcompetes it.
Exactly. The ibuprofen takes the edge off the painful afterpains, but it doesn't stop the biological tourniquet from working.
Okay, that makes sense. What about the topical spray, benzocaine? You spray it right on the perineum to numb the stitches. What is the trap there?
The trap is a rare but potentially lethal adverse effect called methemoglobinemia. Benzocaine is a local anesthetic. In rare cases, when it is absorbed through the highly vascular mucous membranes of the perineum, it fundamentally alters the patient's hemoglobin. It oxidizes the iron in the blood from a ferrous state to a ferric state.
And what does that mean clinically?
It means the blood can still pick up oxygen in the lungs, but the oxidized hemoglobin refuses to release that oxygen to the body's tissues. The blood turns a dark chocolate brown. The patient will suddenly develop severe cyanosis. Their lips and fingers will turn blue. They will be gasping for air, complaining of shortness of breath.
And the nurse's instinct is going to be to throw an oxygen mask on them.
Exactly. But putting them on 100% oxygen won't fix it, because the problem isn't a lack of oxygen in the lungs, it's the hemoglobin's inability to drop the oxygen off. If a patient using Dermoplast suddenly turns blue and doesn't respond to oxygen, you must immediately suspect methemoglobinemia. The treatment involves stopping the spray and administering a specific antidote called methylene blue.
Methemoglobinemia from a numbing spray. That is a terrifying, highly specific exam trap. What are the memory anchors for this section?
For the assessment, WIDA reads the wound. It guides your eyes perfectly. For the non-pharmacological pain management, ice early, warm late. Ice for the first 24 hours to start swelling, warmth after 24 hours to bring blood flow.
Give me the top 5 takeaways for comfort and chemistry.
Number 1, the RITA scale evaluates perineal healing. A higher score indicates impaired healing or infection. Number 2, SITS bath temperatures must be strictly verified between 34 and 37 degrees Celsius to prevent thermal burns. Number 3, maximize scheduled non-opioids like ibuprofen and acetaminophen to limit the need for opioids, which pass into breast milk and cause severe constipation. Number 4, know the organ toxicities. Acetaminophen attacks the liver. NSAIDs attack the GI tract and kidneys. And number 5, benzocaine spray is topical only. Monitor for sudden oxygen-resistant cyanosis, which indicates methemoglobinemia.
Excellent. We are down to our final myological and psychological phase. The shield in the mind. Immunizations and psychosocial adaptation. We have physically stabilized the patient. We manage the bleeding, the fluid shifts, the plumbing, the hormones, and the pain.
Almost done.
But before they can be safely discharged, we have to protect their future pregnancies, protect the vulnerable newborn, and evaluate the family's mental health. Let's start with the biological shield, immunizations.
There are 3 critical immunizations you must master: Rh immune globulin, the live vaccines, and Tdap. Let's start with Rh immune globulin, commonly called ROGAM. This is one of the most high-stakes, highly tested concepts in obstetrics.
Break down the mechanism for me. Why do we give it?
It all comes down to blood types, specifically the rhesus, or Rh factor. We only care about this if the mother is Rh negative, meaning her red blood cells do not have the Rh protein on them. If she delivers a baby who is Rh positive, there is a massive problem.
Because they're blood mixes.
During birth, as the placenta detaches, some of the baby's Rh positive blood will inevitably mix into the mother's bloodstream.
And the mother's immune system recognizes that Rh protein as a foreign invader.
Exactly. Her immune system acts just like it would against a virus. It creates anti-IgG antibodies designed to hunt down and destroy Rh-positive red blood cells. This process is called alloimmunization. Now, it doesn't hurt the mother, and it doesn't hurt the baby she just delivered, because that baby is already out.
But the antibodies stay in her blood forever.
They do. So 2 years later, she gets pregnant again with another Rh-positive baby. Those IgG antibodies are small enough to cross the placenta. They will enter the fetal circulation, hunt down the baby's red blood cells, and destroy them. This causes severe, often fatal fetal anemia, a condition known as erythroblastosis fetalis.
So missing one injection after the first birth literally ruins her chances of a healthy second pregnancy. How does ROGAM stop this?
ROGAM is a dose of passive temporary antibodies. When we inject it into the Rh-negative mother within 72 hours of birth, the ROGAM circulates in her blood, finds any of the baby's stray Rh-positive cells, and coats them. It basically puts an invisibility cloak over them.
Oh, that's clever.
Because the baby's cells are hidden, the mother's immune system never sees them, and she never forms her own permanent, dangerous antibodies.
That is brilliant. Okay, so what is the exam trap?
The trap is giving it to the wrong patient. A question will say, a mother is Rh positive and her baby is Rh negative. What is the nurse's priority? Students memorize ROGAM for different blood types and administer ROGAM.
But the mom already has the protein.
Exactly. You never give ROGAM if the mother is Rh positive. She already has the protein. Her body doesn't care about it. ROGAM is exclusively for Rh negative mothers.
Got it. The mother has to be negative, the baby positive. What about the live vaccines? The sources mention rubella and varicella.
Rubella, which causes German measles, and varicella, which causes chickenpox, are severe threats during pregnancy because they are highly terogenic. If a pregnant woman catches these viruses, they cause catastrophic birth defects, including deafness, cataracts, and severe neurological damage. However, we cannot give a pregnant woman the vaccine to protect her.
Why not?
Because the vaccines for rubella and varicella are live, attenuated viruses. They are weakened, but they are still alive. If you give a live virus to a pregnant woman, the virus can cross the placenta, replicate in the fetal tissues, and cause the exact birth defects we're trying to prevent. Therefore, live vaccines are strictly contraindicated during pregnancy.
So we give them immediately postpartum before they leave the hospital?
Yes. We immunize them postpartum to protect their next pregnancy. But this creates a massive patient education priority and a favorite NCLEX question. Because you just injected a live virus into the mother, she must strictly avoid getting pregnant for at least 28 days. The virus needs time to clear her system.
So no getting pregnant for a month.
If a question asks what teaching is required after giving the postpartum rubella vaccine, the answer is instruct the client to use highly reliable contraception for 1 month.
What about Tdap? That's tetanus, diphtheria, and pertussis.
Tdap is a bit different. We give this vaccine not just to protect the mother, but to execute a strategy called cocooning. Pertussis, or whooping cough, is lethal to newborns, but babies cannot get their own vaccine until they are 2 months old.
So you vaccinate everyone else?
Exactly. We give the Tdap to the mother, the father, the grandparents, and anyone who will be around the baby. We create a cocoon of immunized adults so the virus can't physically reach the vulnerable newborn.
Let's shift from the biological shield to the psychological mind. We're sending these patients home deeply sleep-deprived, hormonally volatile, and tasked with keeping a human alive. How do we differentiate between the normal stress of a newborn and clinical postpartum depression?
It requires careful, nuanced assessment. Expected psychosocial adaptations include fatigue, feeling overwhelmed, and questioning their identity. It is also entirely expected for a patient to experience the postpartum blues.
The baby blues?
Yes. About 80% of postpartum patients get the blues. It's driven by that massive crash in estrogen and progesterone we talked about. They might cry for no apparent reason, feel irritable, or be highly sensitive. But the defining characteristic of the blues is that it is transient. It peaks around day 5 and resolves on its own within 10 to 14 days. They are still able to care for themselves and the baby.
So when does it become concerning? What are the red flags for postpartum depression or psychosis?
It becomes concerning when the symptoms are debilitating or persistent. If the tearfulness and despair last beyond 2 weeks, it is slipping into postpartum depression. Red flags include an absolute inability or refusal to bond with the baby.
They just ignore the baby.
Yes, they won't look at the baby, hold the baby, or respond to the baby's cries. Extreme lethargy, refusal to eat, or expressing thoughts of harming themselves or the infant are massive emergencies. Another major red flag is severe, debilitating trauma tied to their birth experience. If they felt ignored, violated, or terrified during labor, their risk for postpartum PTSD and depression skyrockets.
The source material brought up a fascinating concept here regarding how we interact with diverse patients. It contrasted cultural competence with cultural humility. It explicitly tells nurses that they cannot possibly know everything about every culture. Why phrase it like that?
Because for decades, nursing taught cultural competence, which basically meant memorizing textbook lists. If the patient is from culture A, they don't make eye contact. If they are from culture B, they don't eat cold food.
Yeah.
That is stereotyping, and it's dangerous. Cultural humility recognizes that cultures are not monoliths.
You can't just put a patient in a cultural box based on their last name.
Exactly. Cultural humility means acknowledging your own limitations. You approach the patient and say, I'm an expert in nursing physiology, but you are the expert in your own life, traditions, and body. What cultural practices, dietary needs, or traditions are important for you to follow right now to feel safe and supported? You ask, you listen, and you adapt the care plan to them rather than forcing them into a stereotype.
That is profound. It shifts the power dynamic back to the patient. To wrap this final section, what are the priority nursing actions to promote healthy bonding and psychological adaptation?
The most evidence-based intervention we have is promoting rooming in. Historically, hospitals took babies away to a sterile nursery so the mother could sleep. We now know that keeping the baby in the room with the parents 24/7 is vastly superior.
It's better for the baby.
Better for both. Rooming in stabilizes the newborn's heart rate and temperature. It drastically boosts breastfeeding success because the mother learns the baby's early hunger cues, and it forces early continuous bonding.
What are the memory anchors for the shield in the mind?
First, an Rh-negative mom needs a shield. The shield is Rogum, and she only needs it if her baby is positive. Second, live vaccines mean leave a 28-day gap. If you give rubella or varicella, no babies for a month.
Rh-negative mom needs a shield. Live vaccines mean leave a gap. Give me the final 5 must-know facts for this section.
Number 1, Rogum is exclusively for Rh-negative mothers who deliver Rh-positive babies, and it must be administered within 72 hours to prevent alloimmunization. Number 2, rubella and varicella are live vaccines. They are contraindicated in pregnancy and require 28 days of strict contraception postpartum.
Right.
Number 3, the Tdap vaccine creates a cocoon of immunity to protect the newborn from pertussis. Number 4, transient postpartum blues are expected for up to 2 weeks. Anything lasting longer or involving thoughts of harm or refusal to bond is a psychiatric emergency. And number 5, practice cultural humility by directly asking the patient what traditions and practices they need to follow rather than relying on textbook assumptions.
This has been an absolutely incredible journey. I am just in awe of the sheer volume of physiological adaptation a postpartum client goes through. We're talking about shrinking massive organs, aggressively shifting liters of fluid, navigating wild hormone crashes, rebuilding tissue, and undergoing total psychological rewiring, all happening simultaneously while the patient is trying to learn how to keep a newborn alive.
It's a lot.
It is. Thank you so much for taking this dense, terrifying mountain of source material and filtering it down to the absolute ultimate high-yield exam gold. You didn't just give us the facts. You gave us the physiological why, which changes everything.
It has been my absolute pleasure. To the listener, I want you to take these mechanisms, these memory anchors, and these 5-point checklists into your next clinical rotation. Do not view a postpartum assessment as routine paperwork. View it as a critical, highly skilled hunt for safety red flags. You're the final line of defense against a hidden hemorrhage, a silent infection, or a spiraling mental health crisis. Trust your assessments, understand the physiology behind what you are seeing, remember your priorities, and you will be a phenomenal, incredibly safe OB nurse.
You know, we started this deep dive by talking about the messiness of obstetrics compared to the clean binary of a broken bone. And going through all this physiology leaves me with one final thought to ponder. The medical textbooks state that we expect a patient's body to drop from this massive hypervascular, hormone-flooded state back to a quote-unquote non-pregnant baseline in just 6 to 12 weeks. That's the official definition of the postpartum period. But considering the profound permanent changes to the immune system, the structural reorganization of the pelvic floor, the cardiovascular stretching, and the absolute rewiring of the psychological mind, well, is 12 weeks really the end? Or is postpartum not actually a temporary phase of recovery, but rather a permanent, lifelong physiological shift in human development? Something to chew on before your next clinical. Thanks for diving deep with us.